Hi everyone. We are so happy to have Dr. Nick Bansback here with us today. He is going to be doing a presentation tomorrow at the KT Canada conference titled Engaging Patients in Health Economics Research. So Nick, if you don't mind, could you tell us a bit about yourself and how you're involved in knowledge translation?
Yeah, thanks for having me. So I have a background in health economics and decision science. And so through my research, I'm doing work that actually tries to help people make better decisions. So this could be policymakers or patients or clinicians. And it's really about, the link to knowledge translation economics is about choices. And so that's where my research seeks to sort of help people make better choices.
Okay, wonderful. Can you explain a bit what health economics is?
Yeah, so most people think health economics is about costs, but I
thought so.
I want to tell you it's more than costs.
Okay.
It's about choices. It's about value and about making choices and decisions when you have some constraints.
Okay.
And so obviously some of the constraints that we think about is a budgetary constraint. So it might be the ministry only has a certain amount of money to spend on health and where do they spend it, so those are choices. But there's other constraints that we have. We have limited time, which we have to think about how we spend our time. We have limited number of hospital beds. So any sort of constraint where you're having to make a choice about how you best use the resources you have available.
Okay, interesting. And why is it important to engage patients in health economics?
Yeah, so it's a good question, and it's a question that we're only starting to really unravel in the sort of last few years, partly through our work with the BC Support unit. I think the starting point is that if you're making decisions about how you allocate resources, so it might be funding or how we create a system, then in the end, the value that you're getting is the value that the patients receive. And so we have this potentially mismatch that we think, or the people making the decisions think they know what patients value.
What is most important to patients and where money or time
exactly
should go,
And so, but often actually we realise when we ask patients, it's not always aligned with what people think it is.
Interesting.
So I think that's a key starting point for thinking about how to engage patients, because in the end, if we're talking about healthcare, then it is for patients.
Exactly, yeah, that's very interesting. And I know that you are working right now in the field of arthritis. So what are some of the things that you have realized really, matter to patients in these ways that maybe don't really line up with what the people making the decisions think?
Yeah, no, it's interesting. So one of the things is there's, I think the clinical researchers have a great emphasis on wanting to improve benefits. They want to the most efficacious treatment modality available because they think, and that is the most important thing to patients.
So most efficacious meaning like the best health outcomes at the end of it?
The best health outcomes, but often sometimes these clinical outcomes which may lead to something that's meaningful for a patient, but sometimes not, and they sometimes ignore actually there's this really quite important potential side effect or this inconvenience with having to take daily injections or having to travel a long way to go and get my infusion. And so I think good efficacy is really important, but it has to be balanced with these other
costs that the patients are...
Absolutely, and cost is a good one. I think actually we in Canada we sometimes ignore that patients are paying some money for their drugs.
And time and sacrificing other activities.
So it all comes back to value. So which part are patients valuing? And this idea that actually your values may be different to another arthritis patient's values. So how do we make a policy decision that's going to be good for as many people as possible.
Yeah, that's tough.
Really tough. Yeah.
Well, that's very interesting. So you just said, that it's different for each person, so it's hard to make then those overall policy decisions. Is there anything else that you want to talk about in terms of challenges for knowledge translation in your area?
Well, I'm going to talk a little bit tomorrow about how we perhaps need to be thinking about patients' values earlier in clinical research.
Okay, so earlier in terms of earlier at the beginning of the research process or at the beginning of the patient's disease journey?
So in the research process.
Okay.
It could be earlier in the patient's disease process as well, but I'm thinking about earlier in the research process, because I think what we're seeing too much of today is clinical research that spends millions of dollars on the research, comes up with the findings of a successful study or trial, and then it goes out into the market, and we're seeing actually patients don't really want it.
Yeah, maybe it's not a topic that was that important to patients.
Perhaps it did just focus on efficacy and ignored some of these other things.
Yeah.
And so, but by that time you've spent the money, that money could have been spent on something else.
Yeah.
And as a population, we've now potentially missed out on all this money being used on something that would have been more meaningful to patients. So we need to think about patients' values earlier in the design process. Sometimes it's about tweaking the design to make sure the outcomes are appropriate, the ones that match what matters to patients.
Yeah.
Maybe it's including treatment arms that wouldn't always be considered. Or maybe it's actually this trial just shouldn't happen.
Yeah.
But let's make those decisions earlier rather than wasting money.
Of course, it seems like a no-brainer.
It seems like a no-brainer, and what I'm going to be talking about is how this is just the normal way of doing things in the consumer product market. So how Apple makes their iPhones and car manufacturers work, and how airlines design their planes. They think about what their customers and consumers want before they develop.
Yeah.
In health, we kind of don't do that.
That's a really good analogy to sort of understand that it should, be the same way, because ultimately it's for the patient's benefit.
Yeah. So that's where we're going to be taking some of our research forward, and some of it's going to be related to arthritis.
I know this is a bit of a tough question, but so why do you think then that healthcare doesn't operate in the same way as these other fields?
Well, there's good reasons actually.
Okay.
So in Canada, our market for healthcare, we have a sort of a universal coverage, not for drugs, but for most hospital care, and we think that's a good thing.
Yeah.
Because we don't really want people having to go and buy their healthcare
from their own pocket,
particularly if they're sick. So it's a good thing, but the downside of that is, if Apple don't make an iPhone that people want, then Apple will go bust.
Yeah.
But in healthcare, we don't have that same market because of the nature of we're trying to do coverage and we're trying to public system. So that's the main reason. So we don't want to change that. That's my viewpoint.
We pride ourselves on
we pride ourselves in universal, but we can still learn from these ways that consumer models are done in phones and cars.
So in other countries, I'm just curious then, countries that don't have universal healthcare and have a privatized system, then are they much more sort of patient-oriented?
That's a great question. So I won't go into economics 101, sure. But there's sort of it's over sort of 10 different reasons why we don't have good markets in healthcare. One of the main ones is sort of universal coverage, but there's many other reasons why markets don't work in healthcare.
Okay.
And so, and partly just to give you one example is that the knowledge that doctors have, for good reason, is so much more than what patients have. So it's hard. I can go and learn about a car and an iPhone and its features and what it really means. But as a patient, it can be hard for me to really understand
of
that.
Course.
And neither should I, because that's That's why we have doctors and
they have the
health
training and the
professionals to do that.
vocabulary, but it does create a barrier then.
So this is a problem across the world
Mm-hmm.
in healthcare. There's not another country that's got it
Yeah.
right.
Yeah. Okay, well that's very, very interesting. So with your presentation tomorrow, I'm sure we've maybe covered quite a bit of it, but is there anything else that you think is worth highlighting here?
Well, I'm going to actually talk an example about a project where Cheryl Cohen was actually one of our patient partners. And so
Okay.
I think one of the things that as a health economist we're learning how to have patients as partners in our research projects. And it's a process, we haven't done this before.
Mm-hmm.
I think in KT, more general KT, it's something that's been sort of
patient
happening
partners
more
and
in,
research. Yeah.
but in health economics it's a bit new for us.
Okay.
So I'm going to share some of the experiences that we've had, you know, overwhelmingly positive,
Yeah.
but where I think as researchers in health economics we need to learn more about how we can allow partners to be patients to be better partners and when to engage them and how to do that.
Yeah.
So we're on a bit of a learning process. I'm going to share some of those reflections.
That's great, yeah, because it can definitely be challenging, I think, if neither parties are used to working with each other, learning how to collaborate. And I know that Dr. Cleon Hamilton, we just had him in here, and he's working on developing some things to actually help that process.
Yeah.
So to help researchers know how to work meaningfully with patients and some tools there. So that's great.
Now, I think some disciplines are further ahead than others.
Mm-hmm.
We're kind of catching up.
Yeah, well, it's great that that is happening. That health economics is moving in that direction. So, yeah, thank you. I've learned so much from you. I'm sure our viewers have as well.
Good.
So, thank you so much for coming here today, and good luck on your presentation tomorrow.
Thank you very much for having me.
Our pleasure.